Okay, so welcome to today's class. Today's topic is ascites, and my name is Kiranjot Kaur. So let's dive into it. What actually is ascites? Okay, so ascites is abnormal accumulation of fluid in the peritoneal cavity. These are the two things that we have to remember in this disorder. Okay, so what is peritoneal cavity? Peritoneal cavity is the space between the peritoneal organs. Here, the fluid gets accumulated, and the patient feels quite a discomfort. And This accumulated fluid leads to a more like a pot belly appearance. Whole of the patient's body is thin and fragile. We can't say that the patient looks fat. It will be directly just like it will be directly opposite of obesity. In obesity, all the organs are accumulated by fat and whole body appears to be fatty. Whereas in ascites, the whole body, basically the limbs of the patient, they look so fragile, but the belly or the peritoneum gives a pot belly like appearance. Okay, so if we move on to the next slide contains what are the causes of ascites. Okay, so the main cause is the liver disease, especially the liver cirrhosis. What is liver cirrhosis? If you ask, liver cirrhosis is a condition in which the original tissues of the liver get replaced by the scar tissue due to damage. The problem here that arises is that the scar tissue does not perform as the original tissue did. So there is no proper filtration in the liver, which lead to portal hypertension. Okay. So the other causes are heart failure, cancer, tuberculosis, and nephrotic syndrome. These are also the contributing factors, or we can say other causes that lead to ascites. Next, we got the pathophysiology, how this disease goes further on in advanced stages, how basically how this disease progresses further. Okay, so as we read in the previous slide, that the portal hypertension is caused by any kind of liver disease. Okay, so portal hypertension leads to two things. First is hydrostatic pressure in the abdominal blood vessels. Okay, and the next thing it leads to is hypoalbuminemia. Okay, remember, if the word hypo arrives, then we know that the certain thing is in the lower quantity. Okay, so here the portal hypertension increases. Okay, increase in the portal hypertension and decrease in the hypoalbuminemia. And then hypoalbuminemia leads to decrease in oncotic pressure. So here we have seen that here decrease of oncotic pressure is there and increase of hydrostatic pressure is there. Okay. So these are the two things: hydrostatic pressure and basically increase of the hydrostatic pressure and decrease in the oncotic pressure. Both of these contributing factors lead to fluid leakage in the peritoneum cavity. Okay, peritoneal cavity. So both of factor number one and factor number two both lead to leakage of the fluid, and which eventually leads to a disease condition that is ascites. Okay, so this was the pathophysiology. Portal hypertension leads to increase in the hydrostatic pressure and hypoalbuminemia. Hypoalbuminemia leads to decrease in the oncotic pressure, and both factor 1 and factor 2, these lead to fluid leakage, which is eventually known as ascites. So now we'll talk about the sign and symptoms. What the nurse will observe, what the patient will say, both the objective and the subjective data. Okay. First of all, the main sign is the fluid accumulation. That is the accumulated fluid. You can say the patient will come to you and explain that he or she experienced very discomfort in the belly. It feels quite stretching in the belly. Or a patient says that he or she feels quite breathlessness or breathing difficulty. So we have to observe for these signs. These are subjective data that the patient will come and complain to us. First is accumulated fluid, then is abdominal distension. What is distension? Distension is we can say whenever any type of organ that gets stretched out, it's known as distension. You can observe it in the bladder. If bladder gets fully filled up with the urine, then it leads to bladder distension and so on. So here abdominal distension would be seen. There will be obvious swelling. Patient complains of abdominal tightness. These are the common complaints by the patient: abdominal tightness. Then we can see abdominal discomfort or pain, that is complaint of fullness, pressure, mild pain in the abdomen, sometimes sharp or persistent pain if the fluid is present. Okay. So, one more thing we have to observe, that we will be able to see prominent veins on patient's belly. If we'll see if we'll do the inspection of the patient and lift up his or her t-shirt or the top, then we can say that there are prominent veins, because the abdomen, uh, like this, the abdomen has distended, and we can see like this veins on patients. Here is the navel, and here are the veins. We can observe this type of pattern also there. Obviously there will be pot belly or the fluid accumulation. Next we'll see is weight gain, because the fluid is getting filled up in the belly. Obviously it will lead to weight gain. There would rapid increase in the weight due to fluid retention. Then there are breathing difficulties or the feeling of breathlessness. The patient will complain to you that he or she experiences breathlessness, okay, especially when lying down. The reason is that the fluid pushes upward the diaphragm. What is diaphragm? Diaphragm is a muscular sheet present just below the lungs. It marks the, we can say, end of thoracic cavity. So whenever we take breath in, or we breathe in or breathe out, this diaphragm gets contract and relaxed. It's just like a muscular sheet. Here are your lungs, and here is the diaphragm. So diaphragm, it either expands or it relaxes, but due to fluid, here is the fluid accumulation and it's increasing. So the patient will complain that diaphragm, that he or she is feeling quite difficulty in breathing, and the diaphragm will be going towards upwards, and the lungs will not be able to expand as they were used to before during the normal breathing, and the patient will eventually will say that he or she experiences breathlessness. So it's just like a cycle going on. It's caused by pressure on the diaphragm from the swollen abdomen. Okay. So next is loss of appetite and nausea. Obviously, whenever we feel sick, or the whoever feels sick, there is a loss of appetite and nausea. In this condition, these two things increase or get very much, expanded, or too much increased. That is feeling full quickly, or nausea due to pressure on the abdomen, on the stomach. Sorry. So diaphragm is also getting compressed, so are the lungs, and eventually stomach will also feel pressure due to the fluid accumulation. Earlier the patient used to eat about three chapatis or three breads, if we'll say that was a normal meal size of the patient. But now patient will say that after one chapati or after one bread, he or she feels quite fullness and nauseated. The reason is being the stomach is not able to expand properly as it was used to before, due to fluid accumulation. This was the reason. Okay. Next is fatigue and weakness. Okay. So fatigue and weakness are also observed, that is general tiredness, lack of energy, often related to underlying disease that is causing ascites. Okay, so due to the underlying disease, the fatigue and weakness are the obvious signs. Okay, next is swelling in the legs and ankles. Here we will observe the peripheral edema, that is fluid accumulation or the swelling around the limbs. Fluid retention may also cause swelling in the lower extremities. Ankle edema, peripheral edema, these are also observed in the patient due to the fluid accumulation or the fluid retention. Then there is umbilical hernia. In some cases, pressure from fluid can cause bulge near the belly button. So, we'll just make right here patient's abdomen. Here is the navel or the belly button, and here in these areas, in some cases, umbilical hernia is also seen. Okay. So moving on to the next slide. Here we got the diagnosis. How we can diagnose this disease? The first is clinical evaluation. We'll take the subjective data of the patient. Moreover, we'll do inspection. We'll do palpations and percussions as we as a normal RN do. And then there are imaging studies. Next are the diagnostic paracentesis, which we'll further discuss. First, we'll go on with the clinical evaluation. In the clinical evaluation, we'll collect patient's medical history. We'll ask, does he or she have any kind of liver disease, heart failure, cancer, or infection? So these are important to be, collected. Next, there is physical examination. In physical examination, we'll first do the inspection for abdominal distension. When you lift up the patient's clothes, obviously you will see abdominal distension. You will see patient's limbs are quite fragile, or there will be peripheral edema in the lower extremities. Okay. Next, there is palpation and percussion. During palpation and percussion, we'll observe or we'll just hear a dullness during these two actions, and it will indicate that the patient has fluid accumulation in the peritoneum. Okay, so next is imaging studies. In imaging studies, we'll do ultrasound of the abdomen. The main reason for ultrasound is to detect ascites fluid. Okay, so ascites fluid will observe what is the amount of the fluid, and it is also necessary for the diagnostic paracentesis, that is for the amount of the fluid, and to diagnose further guide during the diagnostic paracentesis. Okay. Next, we'll do the CT scan or MRI. Okay, CT scan and MRI. What are the reasons for doing this? Is it is used if ultrasound is inconclusive. If we are not able to do ultrasound, then we'll move on to the CT scan or the MRI to evaluate underlying cause such as tumor, liver cirrhosis, or infection to find out are these the factors that are contributing to citis or not. So we'll just to go for the CT scan or MRI if we are not able to do ultrasound. And then is diagnostic paracentesis. Okay. So what actually is paracentesis? That we'll insert a sterile needle in patient's abdomen. Okay. I'll just explain the paracentesis further in detail in the next slide. Okay. So we'll just go from here. So what happens is during paracentesis, we'll do fluid analysis that will include what is the color of fluid, what is how is it cloudy or not, or is it bloody or is it milky? During paracentesis, imagine this is the patient's belly, and we'll insert a sterile needle to just collect the fluid that is accumulated in the peritoneum cavity. And after collecting that fluid, we look for its appearance, whether it's clear, cloudy, bloody, or milky. Then there is cell count and differential. Okay, so we'll find out after collecting the parasympathetic fluid, we'll see if there is an infection or any malignancy. Then there is albumin concentration, that is to calculate serum ascites albumin gradient, also known as SAG, SAAG. Okay, so this test is also done to do the differentiate. Okay, then we'll go for the protein levels to check and classify any type of transudate or exudate. Then go for the culture and gram stain to just make sure that there is no any type of bacterial infection that is causing it. Then there is cytology to detect cancer cells if malignancy is suspected. Okay, so we'll just go for the cytology too to detect if the patient is suffering from any underlying cancer or not. Next is paracentesis. The what is paracentesis? Here the needle is inserted in the abdominal cavity to withdraw ascitic fluid for analysis. That the analysis was this. After collecting the fluid, we'll do this type of analysis with the collected fluid. Okay. So during paracentesis, what are the main duties of a nurse? We'll just discuss it right now here on. So during paracentesis, care will be provided by the nurse. That is, we will prepare the patient. We'll just explain them what is the procedure. Okay, uh, we'll just clear out their doubts and any type of queries. we'll just know if they are mentally prepared or not. One more thing we have to see is obtaining the consent. A nurse will never obtain the consent. We are just the witnesses. It is doctor's duty or the physician's duty to obtain the consent. We just act as a witness right in front of patient and doctor. We never take any type of consent from the patient. That is the duty of doctor. That is the most important thing that we have to remember. Most of the questions are based on this only, that whether the nurse will obtain consent or not, or she'll just act as a witness. The nurse always acts as a witness. The next is maintain aseptic techniques to prevent infection. Obviously, if we are doing this invasive procedure, this procedure is invasive. So we have to maintain aseptic techniques. There is no other, option for it. Monitor for complications such as bleeding or hypotension. When you're doing paracentesis, there are chances that the bleeding may also occur, or hypotension may also occur, because sometimes when doing paracentesis, the fluid just rushes out of the belly or the peritoneum cavity. It just rushes out like a gush of water. Okay, so there are chances that the patient can also suffer from hypotension or bleeding. The next is observe the puncture site for signs of infection or leakage. Okay, we'll just observe if the patient has any infection, leakage. How will we will be able to see that? The first sign of infection is fever. Okay, there will be obvious some increase in the temperature, or there will be pus like formation on the puncture site. These indications tell us that the patient might be suffering from underlying infection that might have occurred during the parasympathetic process. Okay, so here you can clearly see what actually is parasympathesis in the visual form. So this is the fluid that is accumulated, and this is the accumulated fluid. Here we are inserting the needle. This is the puncture site. Okay, we got the puncture site, and we'll just strain it in a collection container. Paracentesis is both a diagnostic test as well as a treatment for the ascites. Okay, then we can do other tests like LFT, kidney function test, complete blood count to detect an infection or anemia. Okay, then there is kidney function test to see kidney involvement, liver function test to determine the liver damage or the cirrhosis. Coagulation profiles to are done to are done in order to detect any kind of bleeding risk. Some patients that may be suffering from any blood disorders, or might be on anticoagulants, or might be taking heparin, warfarin, and so on. They might be at the risk of bleeding. So that's why coagulation profiles are done. Or we also ask patient before this procedure that are you taking any kind of blood thinners or not. Okay, so this is also thing that we have to ask from the patient, that are you taking any blood thinners. Okay, are you taking drugs for hypertension, or do you have heart diseases? So this is the reason why we ask patients that they are taking what kind of medications that they have been taking, or they are suffering from any kind of medical issue. So that may not put their life on risk during the any type of furthermore tests. Okay, so these are the things that we will ask the patient. So now let's move on to the treatment. In the treatment, we'll just go for the medical treatment first. That is dietary sodium restriction. We will ask the patient to limit their sodium, and the sodium should be less than 2 grams per day. The reason is, wherever patient takes sodium, water just follows it. It's more like that you are eating any salted crackers, and after eating salted crackers, you feel quite thirsty or your mouth feels dry, so you immediately just drink up water. So this is some kind of a scenario or a story that the sodium follows. Wherever sodium goes, water just comes behind it. So if the patient consumes sodium, it will lead to fluid retention. Eventually, fluid will just get accumulated in the peritoneum. Then we can use diuretics. Commonly used diuretics are spironolactone, that is a potassium sparing diuretic, and furosemide, that is a loop diuretic. Diuretic is the one that acts on the loop of Henle in the nephron. Then there is diuretic help to increase urine output. Diuretics are also known as water pills. The reason is they just excrete out excessive water from the body, and this will eventually reduce fluid accumulation. Then there is paracentesis. In the previous slide, I have said that the paracentesis is both a diagnostic test as well as a treatment. So during paracentesis, we will just remove the excessive large volumes of ascites fluid. When we are doing paracentesis as a nurse, we have to observe the puncture site. Okay, that is a priority of ours. Then we have to ask the patient that whether they're on any kind of blood thinners or not. Okay, we will explain it to the patient also. And one more thing we have to see is we have to conduct BP, that is, we have to do its BP measurements before the paracentesis and after paracentesis. We can also do it during the procedure also. The reason for measuring blood pressure is whenever we are doing paracentesis, the huge amount of fluids gets out of the body, which can eventually lead to hypotension and could also cause hypovolemic shock. Okay, so this is the reason if the BP drops below 90, we have to immediately stop paracentesis. Either if we did so to do it, or will if we continue to do it, then the patient can go into hypotensive state. Okay, so the reason for doing paracentesis is to relieve discomfort and respiratory distress. Okay, next we got albumin infusion. After paracentesis, we have to do albumin infusion. The reason is sometimes given after large volume paracentesis to prevent circulatory dysfunction. The reason for giving albumin is to prevent circulatory dysfunction. Then there is treatment of the underlying cause. We have to go for the underlying cause. We have to treat it. So if you're not treating or you're not going to the root of the problem, then there is no, you know, effort, or there is no, potential result that you will get. So you have to go to the underlying cause and treat the underlying disease. Okay. So next is transjugular intrahepatic photosynthetic. Just a second. So the next medical management will go for is transjugular intrahepatic photosystemic shunt, that is also known as STIPS. So what is this? This is a less invasive procedure and a procedure to reduce portal hypertension by creating a shunt within the liver. So here we'll just create a shunt within the liver to reduce portal hypertension. If we'll reduce the portal hypertension, then eventually the patient will feel less discomfort. Then is it is used in the refractive ascites not responding to medical treatment. If your patient has refractive ascites and he or she is not responding well, or there is no progresses in the recovery or in the wellness of patient, then we'll go for the transjugular intrahepatic photosystemic shunt, that is also known as TIPS in short form. And the last resort is liver transplantation. If nothing works, then we'll have to just go for the liver transplantation. Transplantation also have its own, criteria. First, we have to find the donor. Then have to get it matched. Okay, that whether the donor is a match or not. Okay. Another thing is we have to give patient immunosuppressants during trans transplant, because sometimes patient's body might reject the new liver. Okay, so that's why we have to put patient on immunosuppressants. And one more thing during immunosuppressants is we have to maintain strict aseptic techniques because the patient's immunity is at staggering low. We don't want patient to get any kind of nosocomial infection. So that's why we have to use aseptic techniques, just like in a uh, kind of, you can say, we can't allow any type of visitors who are suffering from cold or any other flu like symptoms to go near the patient. We have to prevent any type of flowers or those bouquets to come in contact with the patient or everything. We have to observe proper hand hygiene to maintain the aseptic techniques because the patient will be on immunosuppressants to liver transplant. Then there are the complications. The first complication is spontaneous bacterial peritonitis. Okay, this occurs if the paracentesis is not done with the proper aseptic techniques. So it occurs due to that. Then there is hepatorenal syndrome, that is progressive kidney failure in patients with severe liver disease or ascites. Respiratory difficulties, umbilical hernia, electrolyte imbalance, and malnutrition. During respiratory difficulties, we can't give patient lying just straight lying position. We have to provide them semi fowler or fowler position, because at these positions, semi fowler fowler, there would be enough space for the patient's lung to expand. Okay, then we will move on to the nursing management. What we'll do is we will measure the abdominal girth. Okay, so at regular intervals or every day, we have to measure patients. Here is the patient's abdomen. We have to take a measuring tape and measure the abdominal girth to determine that the fluid is accumulating more or the paracentesis is working or not. Okay, to assess fluid accumulation. Then we have to go for the signs of respiratory distress or discomfort. Okay, so we have to relieve respiratory distress of patient either by providing them a comfortable position, by ailing them with the other respiratory aids. Okay, we have to address this issue as well. Then go for the vital sign. Of course, we'll go for the temperature, we'll go for the BP, we'll go for the respiratory rate, okay, and so on. We'll just go for the vitals to check if there is any abnormality or not, especially for fever, because fever denotes as the possibility of infection. Okay. This is the first sign of infection. I have told you that the BP will be conducted to check if the BP levels are within the normal range or not. If it's low, then chances of the patient could suffer from hypotensive, uh, could be in the hypotensive state. Then go for the assess for peripheral edema. We'll just check if there is peripheral edema or not. These are the signs of electrolyte imbalance. Okay. If whenever a patient suffers from electrolyte imbalance, you have to address it immediately, because any type of imbalance in any of the electrolyte, it can eventually lead to cardiovascular problems. Your patient can go into cardiovascular uh, complications. So monitor intake and output closely. This is a very important sign. Intake and output must be observed clearly and closely. But should be always known. So we have to see what patient has took in or what he or she has consumed and what is the output. We have to do some mathematical calculations here to find out how much fluid is in the body and how much is the out, how much patient has taken in as a diet. Next, we got supportive care. Okay, assist the patient in daily activities, provide comfort measures for abdominal discomfort. You can provide them comfort devices, assist with mobility, positioning to ease breathing. These are the things that patient will do. Sometimes you can also ambulate the patient also. Then there is supportive nutrition needs and encourage small frequent meals. Patient will complain that he or she cannot eat a normal meal sizes, so just go for small frequent meals. So at last we got the patient education by RN. It is duty of RN to educate the patient or to provide patient education. That's what RN can do. No other less nurse can do that. Only RN can provide the, no LPN, no UAP, nothing. No one can provide patient education. Just RN can provide the patient education. We have to educate about sodium restriction, fluid management, teach about medication adherence, that do not discontinue your medication until and unless your physician had told you so. Do not do by your own choice. You know that then after that relapse can occur, especially the diuretics. Potential side effect. Tell them the potential side effects. Okay. Then we have to inform about in tell the patient that if you experience any kind of complication like infection, worsening symptoms, or fever, fluctuations in the blood pressure than the normal range, then inform it immediately. These might be the complications. Encourage the patient to have regular follow ups, report any new symptoms. Okay. So these are the things that we will ask patient to do and teach them. So thank you for the class.